Currently, there are commercially available genetic markers and testing that can be provided on the fine needle aspiration biopsy. Any endocrinologist or any surgeon who perform a biopsy can collect the tissue for genetic testing, and I'm not going to mention any names, but this is currently commercially available. And by knowing that, you can make a decision about, for example, if you're definitely treating cancer, if the cancer has certain mutation, can be aggressive versus not. One important study that I want to mention here, that there is a study out of China where they looked at over 1,500 patients with thyroid cancer when they did the ablation, and they compared patients with BRAF mutation to patients without BRAF mutations. BRAF mutation in general is associated with higher risk of metastasis or recurrence. And what's interesting in that paper, that maybe 65% of the patients were BRAF mutant tumors. And there was no difference between the patients who were BRAF and not BRAF. There was no difference in outcome. So BRAF really, according to that paper, should not really make us decide if the patient needs or can be a candidate or not for RFA. Having said that, they did not look, for example, at more important mutation, which is TERT mutation. Well, TERT mutation is associated with significantly higher risk of metastasis, can affect really survival. If a patient has a TERT mutation, I would not offer radiofrequency ablation. I would consider in these cases to remove it. The good news is that the TERT mutation is present in a very small number of cases, a single-digit kind of percentage of cases. So if it's not there, then I think a patient will be a very good candidate. The other indication to do genetic testing, long time ago, we used to routinely operate on patients who have indeterminate nodules, meaning they see on the biopsy like follicular lesion of undetermined significance, follicular neoplasm, etc. Well, now we also have commercial available testing that can look at different genes. Some of these will look at 10,000 genes and have different panels and different platforms that can classify the patient into low risk of malignancy, less than 4, less than 3%, or less than 1%, versus a higher risk, 99%, versus in between. So by knowing that, we can make a decision about how we need to intervene. So for example, if the risk is significantly low, less than 4%, we don't usually operate on these. And maybe if it's a sizable one, etc., we can instead offer these patients an ablation and shrink it or make it disappear. On the other side, if it comes back as cancer, then we know that we're treating cancer and make a decision according to the size of the nodule, etc.